We're going live. I do not work with peds currently. No.
You should. You really should.
I love peds. It's so much fun, but it's not easy because they don't pay you anything. Let me see if I could get. We're going live. We're going live. Oh, I can hear myself, guys. It's terrible. All right. Cool. I'm going to pull up my screen share. Or should I wait to pull it up? I don't know. It's up to you guys.
You can pull it up now if you want.
Okay. Share. Play from start. Okay. Nice. Oh, actually, though, when I go to see the chat, I don't think I can see the chat while I'm in screen share mode. So I'll probably have to just pause it when the opportunity
You should
arises.
be able to. If you click on the chat thing, it should pop up as a side thing.
Oh, here it is. Yep, perfect. You're right. Okay, cool. Nice. Okay, so let's see if I can move this up to the top. Oh my gosh. I don't want to. No, I didn't want to do that. Okay.
Alrighty, we'll be starting in about a minute.
All right.
Alrighty, here we go. Hello, everybody, and welcome to today's virtual shadowing session. I would like to welcome Miss Chrissy. She is a nurse anesthetist, certified registered nurse anesthetist, and she'll be speaking today about her specialty and giving us a little insight about what she does on a day-to-day and just giving us a little bit more insight. So the floor is yours.
All right. Hey, everyone. Thank you so much for tuning into the virtual shadow. I'm excited to share with you guys the best kept secret in healthcare, nurse anesthesia. So let's start with where I started, how I stumbled into this profession. So I actually didn't know I was going to be a nurse. I wasn't sure what I wanted to do with my life. When I went to college, I started out actually as a social work major. But then I decided that I was interested in healthcare and I started taking science courses as electives and just really fell in love with anatomy and physiology. And I just absolutely could integrate my science classes a little bit more and still take my credits from social work. And oh, my internet connection's unstable. Is everything working okay? Can you guys hear me? I'm not frozen. Okay. And so then I switched to psychology as a major and minored in biology and Spanish and graduated with that degree. I ended up doing a pre-med internship in Mexico along the way. And I shadowed an anesthesiologist down there who I absolutely adored as well. And that's where I first realized that anesthesia is not quite so boring as I imagined it would be. And then I decided to, when I came back to the US, I got a nurse's aide job because I wanted to just kind of see what healthcare careers were out there. I was thinking about medical school. I thought about PA school. I wasn't even really thinking about nursing school at the time. And as I got more exposure to the nurses I worked with and this anesthesiologist who was wonderful there, who mentored me, they introduced me to what CRNAs were. And the CRNAs who worked in the operating rooms at that surgery center would let me shadow and encourage me to consider it as a career as well. So I got my second degree in nursing and was very lucky to get into an ICU right away, just by chance. I applied to like a million jobs. And I started working at UPenn as a nurse and the cardiac surgery ICU. And then I went back for my nurse anesthesia degree and my master's degree at UPenn as well. And since then, I've been practicing for about 3.5 years now, and I am in an unnamed academic medical center. I see a couple questions just popped into the chat. Oh my goodness. Okay, these are from you guys. I'm gonna hang in there. So let's talk about what a CRNA is. So this is a picture of Alice McGaw. She is known as the mother of anesthesia. She is one of the most famous nurse anesthetists from the late 1800s who gave anesthesia for the Mayo Brothers patients. So she gave over 14,000 anesthetics without any deaths, which is a really big deal during a time when there were no monitors, no pulse oximeters, no EKG machines. She literally would watch the patient breathe, watch the color of their skin, have her finger on their pulse, and that would give her a gauge of their blood pressure, their heart rate, by how strong or how weak the pulse was. And she would titrate the anesthetic, which was ether primarily at the time, to get them through the surgery safely. So nurse anesthetists have been giving anesthesia since the Civil War in the US. It was a profession that was shared by nurses, doctors, and dentists ever since the history of anesthesia in America. And that's why we have all these overlapping roles. So a nurse anesthetist is someone who has a master's degree or now soon to be a doctorate degree in nurse anesthesia and can give anesthesia in the operating room or anywhere that anesthesia is performed. So things I love about being a CRNA is that it combines the best of medicine and nursing. It's direct hands-on patient care, which as a former ICU nurse, I adore. You have a direct influence over a patient's surgical experience, not just emotionally, like having, that intimate connection where you can help someone feel like you can take away their anxiety or, give them a pain-free experience or reduce their pain or reduce their nausea. But you also can, by making good decisions and creating a good plan, get a high-risk patient through surgery safely. So someone who is at a high risk of a heart attack or a stroke under anesthesia, the things that you do and the decisions you make can greatly reduce their risks of those adverse complications. And if you have, a patient who comes in with a trauma, for example, maybe bleeding, the things you do could save their life. So I really like that you have such a direct cause and effect on a patient's outcome. You get that instant gratification. I really love the fact that you can give a medication and watch the results on the patient's face or on the monitor 5 seconds later. For me, I am not very patient when it comes to those things. So that was my favorite part about critical care and my favorite part about anesthesia as well. I like that you are doing hands-on procedures like intubating, placing IVs, arterial lines, central lines occasionally. We don't actually place them as much as we used to these days. What else? Nerve blocks, spinal anesthesia, epidural anesthesia. It's a lot of fun. Constantly learning. Anesthesia is still mysterious. We still don't even fully know how it works. So there's always new research coming up in the field. It's constantly changing and evolving. Lots of critical thinking. You need to really know your anatomy, physiology, and pharmacology, and constantly integrate knowledge of the patient's comorbidities with what's happening to them in surgery to come up with a plan. We say in anesthesia that it's 90% boredom, 10% sheer terror, and that could not be more true. People always ask me, is anesthesia boring? And the answer is sometimes, but I'm glad when I'm bored because that means the patient is doing well. So, sometimes I like to compare it to a flight. The most interesting and exciting parts are takeoff and landing. They're also the most high risk parts. So induction of anesthesia, going to sleep, and emergence when the patient wakes up. And maintenance, usually during the flight, it's a pretty smooth ride unless some unexpected turbulence comes up. That's a great thing though, right? Like most pilots don't want to go into flying to have an exciting flight. They would like a boring flight. They want the passengers to get to their destination safely. And 10% sheer terror, I think it's a nice thing that we have those opportunities to use our critical thinking skills and act fast and intervene. Those moments are scary, but we spend a lot of time preparing to handle those moments. And when we do a good job and the patient comes out on the other side, it's a really rewarding feeling. The other thing is, you get a really great team environment in the operating room, awesome nurses, surgical technologists, and of course the surgeons. And if you are in an anesthesia care team model, the physician anesthesiologist, everyone's so great to work with. Of course, there are crabby people in the OR like any other part of healthcare sometimes, but overall, you become really close-knit over the years and you become like a little family. So it's really cool to have your OR team. And of course, one thing that people love to ask about is work-life balance. One of the best parts of anesthesia is you work while you're there, but when you're home, there's no paperwork left over. Once your case is complete and you finish your post-op paperwork, it's done and you don't have to think about it again. So you never have a backup of case logs to really work on, other than if you would like to prepare for your cases the next day. So when I'm going into work the night before, I always just take a glance at my cases to make sure I don't have any complex patients or complex surgeries coming up. And if I do, then I'll do a little bit of research. But other than that, there's not a lot of work outside of work, which I like. So how does someone become a certified registered nurse anesthetist? First, you need your Bachelor of Science in Nursing. Of course, you could always get your associate's degree first and get some nursing experience in the meantime while you finish your bachelor's. But to apply to school, you will need the bachelor's, and you need 2 or more years of ICU experience. There are some schools that will let you apply at the 1-year mark, but typically it takes about a year to get into anesthesia school from the time that you interview anyway, because most patients are on a rolling admissions. So generally 2 or more years. And starting in 2022, every single program in the US will move to a DNP or DNAP, so a doctorate degree in nurse anesthesia. Those programs are usually at least 36 months long, 3 years, some are 3.5 years long. There's still a few programs that are master's degree programs for now, but soon it will be a doctorate. Other things that are important for getting into CRNA school, CCRN, that is your critical care registered nurse certification. So essentially that is an exam that you take after you've had some ICU experience, and it shows that you're an expert in the ICU. So many schools require this before you apply. It's not 100% essential. Oh, excuse me for a second. Is everything okay? Oh yeah, I'm doing my live. Oh, he's up here with me. Sorry about that, guys. Anyway, Zoom time's very fun. Okay, so yeah, but most schools will still want to see that you've taken your CCRN, whether it's mandated or not. So I highly recommend it for everyone. The GRE exam is required for some schools, not all. And a lot of schools, what they'll do is if your GPA is below a certain cutoff, usually around 3.5, then they'll ask you to possibly take the GRE exam just to make sure that you're, willing to put in the work and study and up to the academic challenge of graduate school. Grad schools will also want to see that you got involved on your unit, so that you've joined some committees like an evidence-based practice committee, a unit council, or something like that. And if you've gotten involved in any research projects. Now, of course, this is not a must, but all of these things will help boost your application if you're interested. So what's a typical day like as a nurse anesthetist? Well, it really is different for everyone. It depends on where you work and it depends on how big of a place you work in. No 2 days of mine ever look the same. And as far as schedules are concerned, everyone's schedule is different depending on where they work too. So if you think about it, most people get surgery during the daytime between Monday to Friday. So most hours for nurse anesthetists are happening during those times. 7 a.m. to 3 p.m. is definitely a possible schedule if you work somewhere like a surgery center, so 5 8-hour shifts. If you work in a trauma center, you might choose to take call and work 24-hour shifts and break up your week into a 24-hour shift and a 16-hour shift, or a 24 and 2 8-hour shifts. I used to do 4 10-hour shifts at our trauma center, and I recently moved over to our main campus. I left our trauma center and now I'm doing 3 13-hour shifts. So for me, I enjoy the 3 long days. There are days where I work really hard. Around 5 o'clock, the staffing all kinds of shuffles, and I tend to do a lot of different cases in the evenings to help let early staff go home. But I like it because I get a lot of variety too. So you'll be assigned to one operating room that day or anesthetizing location, like interventional radiology, the EP lab, something like that. And whatever comes in your room is the anesthesia that you'll do. So you'll do the anesthesia and whatever procedures are related to the anesthesia for those cases. General anesthesia, what you think of on television, patients going completely to sleep with a breathing tube or an LMA, some sort of breathing device. Monitored anesthesia care, that twilight anesthesia, or regional anesthesia. Maybe they'll just have a nerve block and some sedation. Line placement, if they need an arterial line, a central line, any of those things. Although, to be honest, most cases do not require those things. So that's really more for critically ill patients or, really big procedures. And intubation, like placing breathing devices, like I mentioned. If you're on call overnight or on the weekends, usually most hospitals will have an anesthesia person in-house for that. And if a patient codes or has an airway emergency in the ICU or on the floor, you'll go and place a breathing device, like an endotracheal tube during those emergencies. And if any emergency surgeries pop up as well. So our case study today is about the electrophysiology lab. So that's not a traditional operating room, but really interesting cases happen in there. And it's a lot of times they're high-risk patients with kind of complex cardiac disease. So if we take a look at this picture, it looks like a standard EP lab. This is not my EP lab. I pulled this image off of Google. But if you see the 2 gentlemen standing over the long table, the gentleman that's closest to us is by the patient's feet, and the one to the left of him, or the one farther back, is kind of like up by the patient's like groin area. And that big screen that they're looking at is what's showing them what's going on with the heart. So they have, that one giant screen shows a lot of different things. It shows what's going on electrically with the heart, the different heart rhythms, and they might use some mapping to kind of, if they want to burn an arrhythmia. So if the patient has abnormal heart rhythms, they can actually burn the pathways that cause those. So they might do some heart mapping. It looks like on the right side of their screen, they're looking at the echo also. So the imaging of the heart. And then all the way tucked in the back, that person in the pink lead outfit is either an anesthesiologist or a nurse anesthetist. So as you can see, we do not get a lot of space in the EP lab. We're kind of tucked away. There's an anesthesia machine next to that person. And that big machine that's rounding over the patient's head is known as a C-arm. That is like a giant x-ray machine that can kind of do like live x-rays. So that is how we perform the procedures. The procedures are done by placing giant IV catheters in the patient's groin, threading those catheters all the way up, and then they can work on and inside the heart by use of that x-ray imaging. Here's a picture of another EP lab. As you can see, the person all the way to the right is the anesthesia provider. And again, just to point out that they don't really have a lot of space, but so you can kind of get an idea of the equipment and what goes on in there. All right, so let's talk about our little case study. So our patient is a 38-year-old female with a history of Tetralogy of Fallot, who is status post-repair at age 4, meaning that person already had a surgical repair on the heart when she was 4 years old. She now has progressive worsening shortness of breath and fatigue. When she went to her doctor, they found SVT, supraventricular tachycardia, meaning the area above her heart was causing tachycardia, causing the heart to beat fast. The origin of the rhythm is above the ventricle, so somewhere in the atria. And she is here for an SVT ablation. So the electrophysiologists are going to go in and burn the pathways that are causing those crazy rhythms. So let's review a little bit of cardiac anatomy really quick. So a normal heart has this typical pathway of blood. First, blood comes in through the superior vena cava, the inferior cava into the right atrium. It's going to go through the tricuspid valve, down into the right ventricle. The right ventricle pumps blood through the pulmonic valve into the pulmonary arteries, which send blood to the lungs. That's where blood is going to get oxygenated. And then the blood is going to travel back to the heart through the pulmonary veins, into the left atria, through the mitral valve, into the left ventricle, and then pumped out to the body through the aorta. So the right side of the heart is much weaker and typically has a much smaller muscle that's not quite as strong as the left side of the heart because it's a low flow system. It doesn't take a lot of pressure to get blood from the right side of the heart to the lungs. It's not a very far distance to go, and there's generally not a lot in the way preventing it from getting there. So it's so the right ventricle typically is weaker than the left side. The left side is usually much stronger and thicker because it has to get blood all the way to the body. In a patient with Tetralogy of Fallot, things are changed. Tetralogy meaning 4 tet. So there's 4 main anomalies that happen in this process. So the first thing is that there is some sort of narrowing either in the pulmonic valve or in that main pulmonary artery that makes it difficult to get blood out from the right ventricle to the lungs. It's obstructing the path, and now the right ventricle has to work extra hard to get the blood there. As a result, that normally thin muscle of that right ventricle that normally doesn't have to work very hard suddenly has to work much harder. So they get something called right ventricular hypertrophy. That muscle grows thicker and thicker and thicker. As you can see in this image here, the next anomaly that occurs in Tetralogy of Fallot is there's also a ventricular septal defect. So at the same time, there's a big old hole that is disrupting the separation of the right and left side of the heart. So now blood can actually mix back and forth between the right and left side, which is not so good because we have deoxygenated blood coming in from the right side, and it's mixing with the oxygenated blood on the left side. And that's what's getting pumped out to the body. So instead of oxygen-rich blood going, you have like mixed blood. And the fourth anomaly is it's called an overriding aorta. So essentially the aorta is not in its typical place. It's kind of it's kind of positioned a little bit more into the middle of the heart, which essentially puts it at a further increased risk of sucking up that mixed blood instead of getting more of that oxygen-rich blood. So children who have this must have a surgical repair. If this were not to be repaired surgically, this would not be compatible with life long-term. So to see the side-by-side, just so if you're not familiar with the heart, you can just get another way of looking at it. On the left, you can see the two sides of the heart are nice and separated normally, and it's a nice low flow, wide open system to pump blood from the right side of the heart into the pulmonary artery. In the Tetralogy of Fallot heart, it's very tiny, the outflow tract. And again, that right side of the heart has compensated for it by getting really, really big, and the blood is mixing back and forth between the left and right side. And in this image, you can see the overriding aorta a little bit better. It's really wide, and it's kind of tilted this way instead of that way. Okay. So this is what the surgical repair looks like in these patients. The first thing that they do is they have to patch that ventricular septum. So they have to close that hole so that the oxygen, so that the blood stops mixing from the deoxygenated side and the oxygenated side. So we're going to close the hole. Second thing is they have to either replace that pulmonary valve or that whole section of the pulmonary artery, or bypass it with some sort of stent. They have to do some sort of a repair to that pulmonary artery and pulmonary valve area and patch it, depending on how severe the stenosis was. There might be a resection of the right ventricular muscle. I don't think that that's typically done unless it's like really severe and causing obstruction, but I'm not a cardiac surgeon, so don't quote me on it. So yeah, that's kind of what the surgical repair looks like. So now fast forward to 38 years later, our patient had this surgery done when she was 4 years old. So 34 years ago, this is what her heart is kind of working with. So potential long-term complications for these patients, they can have sinus and AV node dysfunction. So your sinus node is the pacemaker of the heart. That's what tells your heart to beat at the rate that it beats. And the AV node kind of conducts that signal down, and it translates it from the atria to the ventricle. So it listens to the sinus node and it tells the ventricle to respond. So those are your pacemakers in your heart, essentially. So dysfunction of those, atrial and ventricular dysrhythmias. So essentially, that's, even though we've repaired the heart, it's still not 100% perfect. So we're still going to see a lot of strain on the right side of the heart over the years. And anytime that we have strain on the heart over many, many years, we can start to develop dysrhythmias, as well as a sequelae of lots of other complications. There could be some residual pulmonary regurgitation or stenosis, meaning that valve that is normally the doorway between the right ventricle and the pulmonary artery leading to the lungs. It could have some backwards blood flow, regurgitation, or stenosis, meaning it could be like a little tight and closed up. There could be residual ventricular septal defects, so there could still be a little bit of a hole in the heart, a little bit of mixing as well. There could be left ventricular dysfunction, so trouble pumping the blood out to the body, a little bit of weakness there. You could have some pulmonary hypertension, meaning the blood pressure in the pulmonary arteries, the vessel that brings blood to the lungs, could get high blood pressure and again cause more strain for the right side of the heart. And of course, right ventricular dysfunction, which is like the number one thing I think we worry about in these patients. How is the right side of the heart doing? Is it handling it okay? Because when the pulmonary artery pressures get too high and the right ventricle gets too weak, you could lose forward flow. And that would be a situation that would not be compatible with life, like a pulmonary hypertensive crisis or something like that. So for these patients, we need to be really aware of their recent echo. We want to know how their right and left side of their hearts are doing, how it's functioning, what's going on in that pulmonic valve, what's their pulmonary artery pressure like, and are they having any rhythm problems, and how are they getting around? Do they have shortness of breath, or are they able to go about their normal daily activities? If they're starting to have a lot of fatigue, shortness of breath, and symptoms like that, there could be something going on. So whenever you're giving anesthesia to a patient like this, the first thing we need to do, as I already mentioned a million times, is support that right side of the heart, support the right ventricle. So we don't want them to be very, very dehydrated, because the heart depends on preload, meaning it needs to be filled up with an adequate amount of fluid in order for it to adequately expand and then contract back. But we also don't want to overload it. That could be a lot of work for the right side of the heart if we give it way too much fluid. So we want the patient to be hydrated, but not overloaded. And we want to avoid increased afterload. So we don't want to just be cranking up like vasopressors, like phenylephrine or vasopressin, something that would really squeeze the blood pressure without giving the heart some support to overcome that. Other things that could increase afterload would be increased pulmonary artery pressures. So again, that right side of the heart is working directly to pump blood to the lungs. So if that blood pressure along that pathway is too high, it's going to be too much stress at the right side of the heart. So we need to avoid things that are going to increase those pulmonary artery pressures, which I will talk about in the next slide. We want to avoid increased intrathoracic pressure. So if the patient's on a ventilator, we need to keep their airway pressures nice and normal or low. If we start pushing air in and out of their lungs with a ventilator and it doesn't agree with the patient, we could generate a lot of pressure in the chest cavity. And that could really change how easy it is for the heart to pump against it. We want to keep their blood pressure as close to normal as possible because that is whatever's working for them. We need to just try to match that. Our anesthesia tends to lower the patient's blood pressure, so we have to be ready to bring it back up. These patients could have a hole in their heart still, so we need to make sure there's no air in any of our lines or syringes. We're always cautious about this in normal patients, but we need to be extra, extra, extra cautious because an air bubble in a normal patient, a small air bubble typically doesn't really do anything to them. It usually just kind of gets absorbed in the lungs and it doesn't really affect the patient. But if you have a hole in your heart, the air bubble could travel to the left side of the heart and end up going to the brain. And that air embolus in the brain, as little as 3 mLs of air, could cause quite a big issue. It could obstruct blood flow in the brain and cause a stroke. External pacing available. So if I were to be doing a case outside of the EP lab, like let's say even just removing an appendix or something simple like that, I would make sure they have external pacing pads available in case they go into a unstable rhythm that we have to either pace over or defibrillate. And no matter what the procedure, whether it normally requires antibiotics or not, you have to make sure that they get appropriate antibiotic prophylaxis because these patients with all of their stents and patches are at risk for infection forming on those sites. So the American Heart Association actually has recommendations for antibiotic prophylaxis for these patients. So if you ever are even doing like dental anesthesia or something really minor, you can look up what the appropriate antibiotics are there, make sure they have them. So how do we avoid allowing the pulmonary, increased pulmonary vascular resistance? That's what PVR is, or increased pressures in the pulmonary artery. We need to make sure that we don't have too much sympathetic stimulation. So too much adrenaline going, too much of that fight or flight. So if your patient's very anxious, you might want to give them some anti-anxiety medication. But with anti-anxiety medication, there comes the risk of slowing down their breathing rate, or if they have sleep apnea, perhaps obstructing and like causing essentially snoring and the buildup of carbon dioxide. And too much carbon dioxide in the bloodstream actually increases the pulmonary artery pressures. So that's bad. So we need to balance the risk of the CO2 buildup with helping the patient relax. So that takes a lot of assessing the situation and close monitoring. You want to make sure that they're well oxygenated. Hypoxia, low oxygen levels will increase the pulmonary vascular resistance as well. So for these patients, you either want to sedate them very, very lightly or do general anesthesia so that you can really control the amount of oxygen and carbon dioxide that is in their body. Once you go into that deep sedation territory, it's really easy for carbon dioxide to build up in the bloodstream, and it puts the patient at an increased risk for, apneic episodes where they stop breathing, or, essentially just obstruction where the soft tissue might collapse in their airway and it'd be harder to exchange air. So again, that would put them at risk for hypoxia. So that would be very bad. And if we do general anesthesia, you want to keep their airway pressures as close to normal. So for those people who are ICU nurses or who are already familiar with ventilators, this is not the patient to use a high PEEP strategy for. That's extra pressure in their thoracic cavity that they don't need. So normal PEEP or even no PEEP potentially, depending on what's going on with the patient. And if the patient is does have very high pulmonary pressures, or if you are monitoring them, they're going up, or you get into a emergency, you want to consider using pulmonary vasodilators like inhaled nitric oxide or Flolan if necessary. Now, if you are not already familiar with these medications, don't worry about them. They are not going to come up very often in your life unless you work in cardiac or specifically here. So back to our patient. Now that we've talked about Tetralogy of Fallot. She's 38 years old. no known drug allergies. She had that repair when she was 4. And now, once again, I already mentioned she's getting progressive shortness of breath and fatigue, which is a bad sign, right? That is a red flag, like, woof, what's going on? Is her heart going into failure now? Something's changing. So, shortness of breath and fatigue happens when the heart can't get blood to, your lungs, to your brain, to everywhere that it needs to go, right? And also when you have decreased oxygen coming to your heart muscles itself, right? Your heart is a muscle and it also needs its own blood flow. So when you have poor circulation and a low blood pressure, you actually might not be getting enough blood flow to your heart itself. That's how heart attacks happen. So anytime a patient gets worsening shortness of breath and fatigue anywhere in life, whether they have this history or not, you need to be thinking about what's happening with their heart. Is it a lung issue? Is it a heart issue? Is it both? So in her case, they did an echo. She was developing severe pulmonic regurgitation. So that valve, again, that separates the right ventricle from the pulmonary artery, is now regurgitating blood backwards. It's having some backwards blood flow. The right ventricle is dilated and it's starting to have some diminished function. The ejection fraction, the amount that it's squeezing out, was 49%, which is not great. It's not terrible, but it's not great. We'd say that's moderately decreased. She had a small PFO, that's a patent foramen ovale. It's a little hole in the heart between the atria, the top of the heart, that exists in fetal circulation, and in most people it closes in the first 2 weeks of life, but in some adults it remains. And she had a severely dilated main pulmonary artery, so she needed to have a pulmonary valve replacement, but because the main pulmonary artery was so dilated, she is going to have an open surgical repair. So in January, February, I believe she's supposed to have a pulmonary valve replacement. But right now, what they found on her workup is that she actually has also new onset SVT, that's supraventricular tachycardia that we mentioned before. So it's a heart rhythm where the heart's beating too fast and the origin of the arrhythmia is coming from the top of the heart. And she's also having some episodes of ventricular tachycardia, meaning from the bottom of the heart intermittently. So before she goes into her surgery, she has to have the SVT ablation done. So essentially, that's where the electrophysiologists are going to go in and burn the pathways to repair that. According to her cardiologist who did the workup, she was at intermediate risk for sudden cardiac death. So that makes us very nervous, obviously, that we're taking a patient who's already at risk here and we're giving her anesthesia. And we're messing with her normal physiology. We're messing with her normal flow states. We're going to be changing the pressures going on in her heart and in her lungs and in her body. So what do? We have to come up with a plan that's going to be safe for her. So we talked to the team. We didn't talk to just one person or 2 people. We talked to everyone. So we talked to her congenital surgeon, the one who's did her surgery many years ago and still follows her, and who is going to do her surgery in 2021. We spoke with that surgeon. We spoke with the EP physicians, the ones who are performing the procedure of the day. We have a cardiac anesthesiologist who was working with me during case. So we spoke as well, and we prepare the nurses. We tell the nurses what to expect, what we're at risk for, and we tell them, we give them a heads up, like, hey, this is what's going on with the patient. This is our plan A. This is our plan B. And that way they know, like, if they should grab any extra equipment for the room, or, if an emergency were to happen, they can be ready to jump into action right away instead of being surprised and caught off guard. So when you prepare ahead of time and have everyone on the same page, that's when things go according to plan. When you take shortcuts, that's when things go wrong. So our plan for her was to, so what's an interesting thing about the EP lab is, in order for the doctors to see the rhythm that's going on, it's actually easiest for them to have the patient awake. A lot of our anesthesia medications actually stop or diminish abnormal heart rhythms. So if we give this patient a lot of sedation or general anesthesia, they might not be able to find the rhythm when they're mapping and burn the pathways. So it's actually best for them if we give the patient minimal sedation. Like I said in the beginning, most EP procedures are done through IV catheters from the groin. So, they're not really painful. They give lots and lots of local anesthesia for that part, and you could technically be wide awake. most patients need a little bit of sedation to at least keep calm. So, and just to get them through that part because it's a little bit uncomfortable. But after that, we keep them, I'd say, mostly awake, kind of in that light twilight anesthesia. So for her, since it was that light anesthesia, we felt that we can get away with standard monitoring, meaning a blood pressure cuff, regular EKG leads, a pulse oximeter, an end tidal CO2 monitoring, meaning watching the carbon dioxide that she breathes out. But we did have all of our emergency equipment out and ready to go in the room just in case. Like I said earlier, I mentioned defibrillator pads. We always have them on EP patients anyway, because sometimes when they're inducing different rhythms, sometimes they will purposely induce certain rhythms or accidentally induce certain rhythms. So we need to be ready to shock the patient. Our plan was to avoid excessive sedation. So we don't want that carbon dioxide to build up. So we don't want to make her too sleepy. And I couldn't give that anti-anxiety medication, midazolam, even though she was nervous, because that's one of the medications that actually stops SVT. So the doctors can't really do their job. And no lidocaine either. A lot of times we give lidocaine with propofol to numb the veins, but lidocaine actually is an antiarrhythmic as well. It stops arrhythmias. So we couldn't use that either. So just a simple face mask with oxygen was the airway plan for her. No devices in her because this lady was going to breathe on her own. And here is our backup airway plan. So, a breathing tube is always our plan for an emergency in any major anesthetic. But when you are preparing for the worst case scenario, I always think it's a good idea to have a video scope in the room. That's what you see on the left. So a CMAC or a glide scope. Those are two common brands of video laryngoscopes. And that way, if your patient has any difficulty at all with intubation, you can just go straight to that. And it kind of helps you see around the corner with the video camera. So it's a little bit more of a guarantee that you got the airway, or it increases your likelihood of getting the airway on the first try versus a traditional blade like the one you see on the right. This is what standard monitoring looks like. I just grabbed this picture off the internet as well, but you can see we have our EKG on top. The blue number is your pulse oximetry. That's your oxygenation levels. This white waveform is one that is really important to point out because you don't see it on normal floors of the ICU. So if you're rotating through different places other than the OR, you might not be as familiar with this. But end tidal carbon dioxide allows us to make sure that you're not only exchanging air, but you're exchanging air adequately. So, getting oxygen in and out of your body is very important, but getting carbon dioxide out is even more important in this patient, or equally important, I should say. So that waveform allows me, each time that blip goes up, that's an image of the patient breathing out. That's tracing the exhaled breath. When it falls flat, that's when they're no longer exhaling, when they're breathing in. And the end tidal CO2 is often closely correlates with what your carbon dioxide is in your bloodstream. So whatever this number is on the screen, your bloodstream probably has 5 to 10 millimeters of mercury more of carbon dioxide. So if the number is 20, your CO2 level might be 30. If the number is 30, your CO2 level might be 40. It's not as accurate when a patient just has a face mask on. So in her case, I wouldn't necessarily hedge my bets on that number or obsess over it because we don't have a closed system. A lot of the air that she's breathing out could be leaking around the mask into the environment. But at least by seeing that nice steady waveform, I can make sure that she's not having a big buildup in her bloodstream. And then, on the bottom, we're watching her blood pressure closely. Other things we have in the room in case of emergency out and ready to go are an ultrasound machine and supplies for an arterial line. If there were any issues with her blood pressure at all or any changes, we would want to get an arterial line very quickly. So having the ultrasound out allows us to, again, increase our chances of getting it fast and on the first try. So on the top, you could see they're inserting a needle into the patient's artery and holding the ultrasound probe. And on the bottom, you can see that image of what that looks like. That big black circle is the artery, and that little white dot in the middle is what the needle tip looks like. Here is our defibrillator that we have in the EP lab for every patient. This is what you see on TV when they shock patients. things that Grey's Anatomy lied to you about. We don't use paddles anymore. That's so old school. People have stickers on them. And the other thing, of course, is that we don't shock people when they're flatlined. It doesn't work. You only shock people when they're in VTAC or VFib. Just a fun side note. All right, so our plan of care for this patient, again, a light anesthetic, keeping her mostly awake. We use a remifentanil infusion. It's a very, very potent opioid. It's very similar to fentanyl, except far more potent and far shorter acting. It's metabolized by plasma esterases, so little enzymes that float around in your bloodstream, chew it up. So what's great about it is that it goes away in about 8 minutes. So from the time you turn it off, it's out of your bloodstream in about 8 minutes. So it's very easy to titrate and allows us to easily adjust the depth of sedation for this patient and get her comfortable in a way that's safe. So if you go too high on it and it slows down her breathing too much, it's easy to dial back and wake her back up quickly, as opposed to something longer acting. Propofol, we can just run a very, very light dose infusion just to help sedate as well. And then we have our vasopressors in line, epinephrine to support the heart, help it pump better, and phenylephrine to keep the blood pressure up. Again, our anesthesia makes blood pressure go down, so we want to keep her close to normal. Other things are cefazolin, that is our antibiotic. Ondansetron or Zofran is an anti-nausea medication. Ketorolac is, or Toradol, it's kind of like an IV, I like to say it's like IV ibuprofen. It's its own medication. It's not ibuprofen, but it's the same class of drugs. And a tiny bit of fentanyl just to get through, just to get her over the hump when she was having some discomfort at the end, just from laying on the table for so long. During the case, she initially tolerated the minimal sedation well, but then as things got on, she got a little bit more anxious, a little bit disinhibited, a little confused. So after we had a conversation between the electrophysiologist, myself, and I also made my anesthesiologist aware, and we decided that she would be an appropriate candidate for moderate sedation because she was tolerating the anesthesia quite well from a hemodynamic standpoint, meaning her blood pressure was fine. She was doing well. She had a great airway. It was easy to get her to exchange air in and out. So she was not at a high risk of obstruction or building up that carbon dioxide. And we really wanted to avoid going to general anesthesia. So we made the anesthesia a little deeper. We just went up on the drips a little bit, and she did great. She just needed a little bit of airway support with me just pulling on her chin like this to get her to exchange air well. However, going up on sedation did make her supraventricular tachycardia go away. So the team had to start her SVT back up again by giving isopril, which is an IV medication that essentially raises the heart rate and increases the likelihood of these rhythms reappearing. We use it in patients during these procedures, and it's also used on patients after heart transplants to keep the heart rate high. And it was successful. They were able to see the pathway and finish burning it, and we turned off everything and she did great. Afterwards, she was completely stable in the PACU. She had no memory of the procedure and she was comfortable and pain-free. So we got through the whole thing very safely. So, what is the moral of the story? The moral of the story is that anesthesia is essentially, it's a potpourri. Every day is different. Sometimes you're taking out an appendix. Sometimes you're doing an endoscopy. Sometimes you're doing a Whipple or a giant cancer procedure or a liver transplant. But no matter how small or simple or straightforward the procedure is, the most important part of our job is to understand what's going on with the patient, what are their disease processes, and what is the surgical team doing to them. And that is how we, make our anesthesia plan A, B, and C, prepare for emergencies, and prevent complications from happening. So that is the most important part of our job. So wow, there are so many good questions here. So let me just finish out telling you guys my tips for students, and then I'm going to answer some questions. So if you're interested in CRNA, and these tips also go for if you're interested in really any field of medicine, get direct patient care experience early. I cannot emphasize this enough. Whether it's becoming a nurse's aide, a patient care technician, those are two of the most hands-on kinds of jobs you can get in healthcare that really get you in the hospital, really get you not only comfortable with working with patients and getting exposure to different diseases and treatments, but also gives you great connections with nurses, doctors, respiratory therapists, physical therapists. Really, it just exposes you to a wide variety of careers. So if you're not sure what to do with your life, I cannot recommend this enough. Another great direct patient care opportunity is becoming an EMT. That's another really good one. But if you think that you might want to work in a hospital one day, I think the best thing you can do is definitely like a CNA job. Second is get involved wherever you are. So if it's at your school, on your unit, if you're already a nurse or a CNA, get involved with your state organization. So if you want to be a PA, if you want to be a physician, if you want to be a nurse anesthetist, start seeing if you could go to some of the meetings for your state organizations. Usually there's student discounts, and you can just like learn a little bit about what is going on in your field and make some really cool connections there. Number three is be a team player, whether it's at school or at work. Those people who have a good attitude and good teamwork skills are the ones who get the best recommendations, who make the best connections. And, you know, as you can see from this case study, like anesthesia is totally a team sport, right? I can't make a plan like that alone. I have to talk to two kinds of surgeons, someone who specializes in cardiac anesthesia, as well as nursing staff. It really takes an entire team to take care of a patient safely. So that is like one of the best things you can start practicing now. Be patient. It takes a long time to get there. You know, it's at least 2 years in the ICU. Most people don't get an ICU job right away. It might take a long time before you get to your end goal, but each step in the journey and each step in my educational path really prepared me well for this. And I don't think I would be as good of a CRNA as I am today if I didn't have all of those unique experiences. And the last thing is to be kind to yourself. Don't worry too much about if you got a bad grade in a course. You know, a lot of people ask me about their GPA isn't perfect, or, oh, I'm starting too late, or, oh gosh, like I don't look like this person. My resume doesn't look like them. You are on your own unique journey. And the most important thing is to be kind to yourself. All right. So we have a lot of questions. Let's start from the top. So someone asked, why did I want to become a CRNA as opposed to an anesthesiologist? Where do I see my field going in terms of advancement and growth? I answered where I graduated from, so that's helpful. In cases that a CRNA does anesthesia for, the answer to that one, Jasmine, is every kind of case. Any type of surgery, there are nurse anesthetists doing it. I do anesthesia for every single kind of case you could imagine. The only thing I don't do right now is OB, pediatrics, and cardiac, but we do have CRNAs at my institution who do cardiac. And I'm hoping to do cardiac next year. We'll see, fingers crossed. We will be doing OB next year as well. And peds, you know, it's just not at my hospital. I decided to become a CRNA. Oof, it's so hard as opposed to anesthesiologist. I went back and forth so many times. I think since I wasn't fully committed to anesthesia, I wanted to keep an open mind. I think that becoming a nurse first and leaving my options open made more sense to me. So I liked the idea of giving myself the opportunity to fall in love with nursing. You know, nursing has so many different pathways you can go. You know, besides just working in the bedside, you know, there's a million kinds of bedside jobs, right? You could be working in pediatrics, you could work in geriatrics, ICU, ER, OR. There's a million different things. But you can get into education. You can work for an insurance company. You can do medical device sales and travel the country and sell medical devices. I mean, you can do anything as a nurse. So it really is such a flexible field. So I think that is kind of like what made more sense to me. And then once I was an ICU nurse, I really enjoyed critical care. And I loved what I was doing. So I knew that anesthesia was right because I figured, gosh, this is going to be like all my favorite parts of the ICU and none of my not favorite parts. So, you know, getting to do all that critical care stuff, but only focusing on one patient at a time was perfect for me. So once you're already an ICU nurse, you're kind of like halfway down the road of becoming a CRNA. Just finishing out CRNA school makes so much more sense than, you know, going back and starting med school at that point. And, you know, we do have so much overlap in what we do during the day. I like that when you're in an anesthesia care team model, like how I am, you know, I like that I'm the one who's in the room directly providing the anesthesia and directly caring for the patient and performing the procedures. You know, I think that the anesthesiologists at my institution have a really interesting role where they do a lot of teaching because we have resident physicians who are learning. So I think they really enjoy that. They do a lot of research, and I think that's something that a lot of them enjoy as well. But you know, what I enjoy is the direct care. So, and of course, there are anesthesiologists who do direct patient care as well. But you know, the anesthesia care team model is what you're going to see more. Do I regret not going to medical school? No, I don't. You know, I think so. Oh, are these two different Jasmines? That's funny. Another Jasmine asks, do I regret not going to medical school? I think that like at one point I used to, until I became a CRNA. And now I don't regret that at all. I really love my job. I find it very rewarding. Pros and cons, she asks. I'm trying to think of some cons. So one con to being an advanced practice nurse in general is that there are, depending on the state you work in and the organization you work in, you could have some limitations. Like, let's see. So a good example is nerve blocks. I was trained to do nerve blocks in my education. I'm licensed to do nerve blocks. I have privileges at my hospital to do nerve blocks, but I don't have a lot of practice doing them because at my hospital, we just don't do them very often. So we have a block team, and our residents have to get their numbers in order to like fulfill their requirements to finish residency. So we have like one anesthesiologist on every day who's doing nerve blocks with a resident. And like, I just haven't gone to practice nerve blocks in a long time. So I wouldn't feel comfortable doing it now without like going back to a seminar or like working at a place where I do it routinely. So that could be a con. Like you could have some limitations like that. Although, I don't know, you could say the same thing if you were a doctor, I guess. Like if you're out of practice with something, you're out of practice. But so yeah, I think that if you go to medical school instead, the one benefit is like you're never going to have a license restriction. Whereas as a CRNA, you can have certain like, not that there's any practice restrictions in the US, but you could have more or less autonomy depending on the facility that you work with. So if that's like super important to you, being fully independent and autonomous 100% of the time, I think it's probably more beneficial to just go to medical school. But you might be sacrificing opportunities to give direct patient care. So you kind of have to weigh, you know, the benefits and your priorities. Yeah. My favorite part of my job, I kind of mentioned in the beginning. I love being so hands-on. And it's not hard to get a job after school. We have a really good job market right now for CRNAs. So someone else asked, you're starting a nursing program this semester. Any tips or advice to help you throughout nursing school? And it's the same advice I tell everyone: to get a CNA job, a patient care technician job, a nurse externship, some sort of direct hands-on experience. I love this question. Do you feel that you're able to make strong connections with patients in such little time? And the answer is yes. It's definitely a skill that you have to develop and practice. You only have about 15 minutes to win over a perfect stranger in anesthesia. You only meet them a little bit before. Patients research the hospital. They research their primary care doctors. They research their surgeons. They Yelp them. They look them up. They do everything they can, and they even YouTube their procedures, right? But they don't get to pick you. So it's really important to have a good interpersonal skills and be able to win them over in a short period of time. But I do feel like I bond with my patients, and when they wake up, they are always so happy. Oh my gosh, thank you so much. It's a really rewarding thing to hear. The difference between an anesthesiologist and a nurse anesthetist, of course, is our training. An anesthesiologist goes to medical school first. That's 4 years, and then does a residency in anesthesia. That's 1 year of either surgery or medicine internship, and then 3 years of actual anesthesia residency in the OR and ICUs. A nurse anesthetist, we talked about our educational pathway already. We do have tons of overlap in what we do. We have the same scope of practice, but you will find that CRNAs tend to work independently, mostly in rural areas or smaller facilities. And in bigger hospitals, we tend to work as a team where the nurse anesthetist is in the room physically providing the care, and the anesthesiologist is overseeing multiple ORs at the same time, and is available for help if we need it, like a second set of hands, or to consult if you have any questions or if an emergency comes up. So that is like one way that you see us working together. Of course, like I mentioned earlier, there are definitely anesthesiologists who just directly provide care as well, but it's just not quite as common. The most challenging aspect of my job is probably, I think, just dealing with personalities in the hospital. But you get good at that over time too. There are so many questions. Oh my goodness. How am I doing on time? I don't want to run over. It's okay? Okay, good. Okay. I answered that one. Okay, this is another nursing school question. So besides becoming a CNA or a nurse extern, what other skills or experiences can you foster during nursing school? So some nursing schools have in your senior year like a preceptorship, where your last semester you can spend in like one specialty, and you essentially are getting trained like more one-on-one there. So I definitely would encourage you to do like an ICU preceptorship if you have that opportunity. And also try to extern in an ICU if you can. And if not, then your second choice should be a step-down unit. Why did CRNA move from master's to doctoral programs? That's a great question. I don't know the answer to that. I think it's just the trend in healthcare overall. The same thing happened for physical therapists. They went to a doctorate program. Nutritionists recently went to a master's program. I think that nursing has gone from a associate's degree to a bachelor's degree. And now there's even direct entry master's degree programs for nurses. So I think that it's kind of like the trend in healthcare to just keep increasing education requirements. The hardest part of my education and training experience before becoming a CRNA was absolutely hands down the transition from being a nurse, being a nursing student, to becoming a new nurse in the ICU. It is such a steep learning curve. People completely underestimate how hard it is. Nobody tells you how hard it is. The ICU is no joke. Patients are so sick. You have so much responsibility, not only for time management and juggling things like giving meds on time, but you're also titrating life-saving infusions and, managing devices that keep people alive, and dealing with multiple interdisciplinary teams like physical therapists, respiratory therapists, doctors from 6 different specialties, lots of different personalities to juggle, all that while you're still trying to manage basic things like how to change the bed while the patient's still in it. So this is a really steep learning curve, and that is why I highly recommend becoming an aide or an extern beforehand. That way you can kind of get down some of those basic skills and work on your time management and work on your confidence ahead of time to smooth out your transition. This is such a good question. What do you look for when choosing a CRNA program? So, such a good question. So, and then also, what made you a successful SRNA, CRNA? And is there anything I missed about that? I love all these questions. Okay. So when choosing a CRNA program and any grad school program, first of all, you should absolutely talk to alumni from the program. There is a website called allcrnaschools.com, all-crna-schools.com. And they sort schools by rank, and they do their own ranking system based on attrition rates, based on how many clinical hours students get before they graduate. I forgot what the third thing was, but they kind of have their own ranking system. They also rank, you can also sort by cost, and you can sort by state and location. So it depends on what is going on in your life. If you're single and you're willing to go anywhere, sort them by cost or sort them by ranking. or look at both and kind of find a school that is in a good middle ground. If you have, family that you need to live nearby, then sort by location. So I think that it's that iron triangle of like experience, cost, and location, and finding the best blend for you. CRNA schools could be anywhere from free to $200,000 for the program. So figuring out where, how much you're able to afford, what you're willing to afford, is really important. But also you definitely want to find a school with like a good ranking system that, has a good reputation for getting students good clinical experiences. I think that's most important. Just because a CRNA program is affiliated with a big university doesn't mean you're going to have great clinical experience. Sometimes you end up competing with residents and not getting all your numbers, or not getting as many numbers as you'd like. Sometimes the rural or more Midwestern or Southwestern schools actually get you more high quality clinical experience. So whatever schools you kind of find on that search that you like, I would write them down and start to reach out and see if you could find alumni through different Facebook groups, or contact the universities directly and ask them to put you in touch with alumni and get a sense for how they liked the program. I think alumni are often very, very honest with you about the pros and cons of different programs. So talking with them is really helpful. Another great resource is this Facebook group called I See You Dreaming About Anesthesia, I.C.U Dreaming About Anesthesia. And it's a whole network of students who are interested in becoming CRNAs, and some CRNAs are on there as well. And we give lots of advice and help each other out. And no, I don't miss a single thing about the bedside, because I'm still at the bedside. I'm more at the bedside than any other time I ever was before as a nurse. When I was a nurse, I was pulled in two different directions. I had family members. I had, like I said, a million team members that I had to go and talk to. I think that people think that anesthesia is leaving the bedside, but it's actually spending more time at the bedside. My eyeballs are on my patient only. I'm not anywhere else other than with my patient the whole time from start to finish. So it's the nursiest nursing job I've ever had, I always like to say. What experience, aside from a job and previous nursing school grades, are helpful for getting into CRNA school? I would say, obviously, ICU experience is the number one, making sure it's a high quality ICU with really sick patients. Lots of, spending more time there is helpful. So the longer you're an ICU nurse, the better it looks on your application. But again, getting involved in committees is super important. If you have an opportunity to get involved in a research project, I think that looks amazing. That's something that a lot of people don't have. I think that could really boost your application. Daily life as a CRNA student, it's tough. There are two kinds of programs. There's front-loaded programs and integrated programs. Some programs put you in clinical from the very beginning, from semester number 2, and they, you spend half the week in the OR, half the week in the classroom. In my program, I spent, in the beginning, it was 3 days a week in the OR for the first semester and 2 days in the classroom. And then after that semester, I think it was 4 days a week in the OR and 1 day a week in the classroom for the rest of the schooling. So those days in the OR were long. I got there around, in the beginning, really early, like 5 a.m. Once I got a little bit more comfortable, about 5:30. So I'd be there from 5:30 in the morning to like 4:30 in the afternoon. And then when I got home, I'd have to prepare for my cases the next day, as well as study for courses. So it is really, really busy. The way that I made time for my family and myself was I made a rule: no studying after 9 p.m. And no studying on Friday nights, and no studying on Saturdays after 5 p.m. So I could study Saturday morning, but once it hit dinner time, I had to have Saturday night off. And Sunday was my catch-up day for meal prep and laundry. And then I could study again at whatever point I wanted to on Sunday. But that way I kept at least Friday nights and Saturday nights to myself. At what point in your nursing career did you realize you wanted to become a CRNA? I think it was after some time in the ICU. I had it in the back of my head for a long time, but the ICU, it really frustrated me when I had 2 really sick patients at the same time and I couldn't give them both my full attention. And that is what really motivated me to go to the OR. I really wanted to just handle one person at a time and give them everything I wanted to do for them. Give them my full attention. It's funny that you also asked this next question about what advice I would give to nursing students who are looking to specialize. There's no need to decide right now. You're going to get exposed to so many specialties in nursing school. And then once you become a nurse, you can keep changing for the rest of your life. There's no need to commit now in any way, shape, or form. So my best advice, honestly, is again, get a nurse externship, get some direct patient care experience to smooth out your transition into nursing. And then try some different jobs. Try, as an extern, you might have the opportunity to try a few different units. But start out on a unit you think you'll like. And if you don't like it, then after a little bit of time there, try something different. And that's the best part about nursing. You don't have to pick. Someone asked, is psychology a commonly accepted degree for nursing? I mentioned looking into PA schools as well. Okay, so for nursing, the only way to become a nurse is to go to nursing school and get a nursing degree. If you're looking for a second degree program in nursing, like if you already have a psychology degree and you want to become a nursing student, yeah, that's totally fine. All that matters is that you get all of your prerequisite programs done. So the second degree programs want to make sure you have your biology, your chemistry, all of those courses. Same thing for PA school, for med school, for anything. It doesn't really ever matter what your undergraduate major is, as long as you do all of your science courses and prerequisites. I think that psychology is a nice degree for before PA school or before med school, because it integrates like science and the humanities and helps you understand a lot of common things that we see in our patients. It's nice to have that background of understanding some common things that we see in patient populations that aren't necessarily emphasized in other parts of medicine. And it helps your people skills. All right, Ravina is asking, at what point in my career did I realize that being a CRNA was for me? Okay, so we answered that. How did I find it from Mexico? So my undergrad, we had like a strong study abroad opportunity. That was something I looked at when I was choosing schools, because I knew that I would want to consider it. And here's something interesting. If you're not quite yet in college, some colleges charge you extra to study abroad. They'll charge you your base tuition plus the foreign university's tuition. And other colleges do tuition exchange, and you only pay for the foreign university's tuition, which is always far cheaper than the American tuition. So one thing that I asked about when I was an incoming student, thinking about the school, was about their study abroad programs. And when they told me that study abroad was based on tuition exchange, I knew that was my ticket to saving money in school. So I was able to get my Spanish minor that way. And there was a pre-med internship opportunity there that my professor actually kind of helped me make. She knew of this program through Notre Dame, where Notre Dame had a relationship with the university in Mexico. And they had this pre-med program, and my professor knew some of the people there, and she spoke to some of the advisors, and we worked out a deal where they let me join them in the hospital rotations and in some of those courses. So I didn't take the science classes with the Notre Dame students, but I took all of the healthcare curriculum with them. That was pertinent to the internship, because that was through the Mexican university, Universidad de las Americas in Puebla. So so if you're looking into studying abroad, I definitely recommend trying to find a college that does tuition exchange. You can save a ton of money. What are some qualities that you feel make a good CRNA? So definitely attention to detail and thoroughness. You have to take full ownership for your patient and full responsibility. Again, being a good team player. There's no room for pride or ego in the OR. So if you think that, you could have potentially, if you don't know something, you have to ask. You can't gamble on a patient by being afraid of looking stupid or dumb. If you think you might have made a mistake, oh my God, did I just give the right antibiotic? Something like that. Who knows? You have to speak up. If you see someone doing something else inappropriate, wrong-sided surgeries happen every once in a blue moon. I've never seen one myself. I pray to God I never do. But you have to pay attention to all of these things that are not even necessarily your job. And you have to be willing to speak up and defend the patient and advocate for your patient. So those are all the things. You have to be able to just really take responsibility for what's going on in the operating room. And you have to be a leader. You have to be a good leader too. You can't just boss other people around. You have to be able to command a room in an emergency and take charge, but also be respectful and get people to work alongside you. I think that's a really essential skill. When an emergency does happen, you will be looked at as the leader and the one making the decisions. So that's a really important thing to take on. And how do you gain confidence in that role and in the OR? It's with practice. It's just practice over time. And that's why the ICU is such an important time. It really helps you gain your voice and develop those skills. Am I still doing okay on time?
Yeah, we just got to wrap up in a little bit. So
How many more questions do you think I should answer?
maybe about 3 or 4.
Okay. All right. Okay. There are no specific requirements for becoming a CRNA during undergrad other than getting your degree in nursing. Where do I see this field in the future? I think that it's going to continue to evolve and change, really depending on what goes on with politics and how. That's a really good question. It really just depends, honestly, on the future of healthcare in America. If we ever go towards like a single payer healthcare system, I think that could definitely affect the landscape of anesthesia. It really just depends. It's who knows. I know that nurse anesthetists are not going anywhere, and that there is definitely always going to be a future for us in anesthesia. I will say that. Whether there will be more jobs for independent practice or fewer jobs for independent practice, I can't say. But for right now, I think that if you are flexible and open to working in either environment, I think that will be in your favor. Let's see. With a doctorate degree, your scope does not change. No, the doctorate degree actually does not increase your anesthesia training necessarily. Like you don't, because the program's longer, you might get more time in the OR, but it's not going to change like what you're allowed to do. There's no extra anesthesia content. The doctorate courses are related to like research projects or like evidence-based practice. They're not necessarily about like increasing your anesthetic skill. This is a good question. So is the work environment stressful? It can be at times. There's definitely production pressure in certain facilities more than others. There are always different personalities to juggle in the operating room. And of course, if the patient is not doing well, that can be very stressful also. But overall, it's very pleasant. I really like my coworkers. I like the anesthesiologists, nurses, and surgeons I work with 99.99999% of the time. And I think that even though there is some stress that inherently comes with taking on more responsibility, I find it very rewarding at the same time. I think that definitely balances out. And has COVID affected our job significantly? Absolutely. We have to give anesthesia for COVID patients pretty routinely. A lot of patients with COVID present with strokes. So we're giving anesthesia when they come into the IR suite for strokes. Some of them are ICU patients who come down for surgeries, various surgeries. And so we're giving anesthesia there. We also were redeployed during our first surge and worked as respiratory therapists in the ICUs on some days. We also like to help manage the ventilators because there weren't enough respiratory therapists to manage the ventilators for all the patients. We also took turns doing different airway shifts overnight where we were, more patients overnight were requiring intubations, and you can't go from a COVID intubation straight back to bed or straight into the OR, straight to the next room. You have to change all your PPE and such. It could be a time consuming process. So we had an extra person on call every night to cover airways and just go to placing breathing tubes. And it was quite busy. And then in the operating room again, covering just emergency procedures. So we were doing all three kinds of shifts. We wear N95s now for every intubation because even though we test our patients, a negative test doesn't mean you don't have COVID. There's definitely false negatives or people who end up, having an increased viral load like 2 or 3 days later. And we're right up in the airway. We're taking really huge viral loads if we don't have protection. So we're definitely at a high risk profession. So that has been very interesting of a challenge, but it's okay. It's good. I feel like we have been pretty protected at my job, thankfully. So we're making it work.
I just wanted to say thank you so much for joining us today and giving us a little bit more of an insight. I think we all have learned a little bit more from Miss Chrissy. Where can they reach you if they have any further questions or they want to, ask you any questions or anything like that? Where can they reach you?
Sure. So definitely feel free to contact me. Probably it's easier on Instagram. My handle is Chrissy CRNA. So CHRISSY CRNA. I have the same handle on TikTok. You can reach out to me there as well, but the DMs are a little bit easier to manage on Instagram. So I recommend that.
Okay, perfect. For the rest of you guys that are joined us on this call, I've posted our shadowing Google form towards the beginning of our Q&A. You guys will have till about 8:45-ish to finish that up. But other than that, thank you so much for joining us.
Thanks, guys.